EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, a student, or a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. I welcome your feedback and suggestions for topics to be considered or any issues you encounter in my summaries of the research. You can reach me through the Contact Me form on any of the websites listed in the show notes. Before we start, I want to draw your attention to the unique EMDR therapy training delivered by Sonoma Psychotherapy Training Institute. Sonoma PTI provides a comprehensive program in 4 two-day modules spread over a 12-week period. These 4 modules include all required hours of lecture, practice, and group consultation. Our Zoom-based program is open to clinicians from throughout the United States, Canada, and Europe. I invite you to look over our curriculum and training schedule at sonomapti.com. In today's episode, we tackle a question that intrigues therapists and clients alike. How does EMDR therapy work? The science behind it is surprisingly complex, and as we'll see, the answers are both multifaceted and truly fascinating. To access any of the original research papers mentioned in the podcast, you will find a complete list of references and links to each of these studies in the March 2026 blog on sonomapti.com. A link to these references can be found in the show notes. You can also just go to sonomapti.com, click on the blog section on the far right of the menu bar, and then select the March 2026 listings. So let's get started with the background to today's episode on how does EMDR therapy work. The question, how does EMDR therapy work, often comes up because of EMDR's signature use of bilateral eye movements. As its name suggests, eye movement desensitization and reprocessing was originally developed using only bilateral eye movements. While most research on EMDR focuses on these bilateral eye movements, other forms of bilateral stimulation, such as kinesthetic methods, are also widely used. For example, the butterfly hug, which we discussed in episode 6 on group EMDR therapy, allows clients to self-administer bilateral kinesthetic stimulation. Some clinicians provide bilateral stimulation with handheld devices. Although bilateral kinesthetic and auditory approaches have been studied, the bulk of research still centers on bilateral eye movements, highlighting their foundational role in EMDR therapy. If you're interested in an in-depth analysis of the theories behind EMDR therapy, I cover this topic in detail in Chapter 2 of the second edition of my textbook, A Guide to the Standard EMDR Therapy Protocols for Clinicians, Supervisors, and Consultants. I also present a detailed discussion on this subject at the EMDR International Association Conference in Minneapolis back in 2016. You can watch a video recording of that presentation or access other home study EMDRIA credit courses at andrewleeds.net. For those who prefer reading, a PDF of that paper is available at no cost in the downloads area. Just check the show notes in your podcast app or visit the March 2026 blog post for direct links to these resources. In today's episode, I'll highlight some of the most compelling and most recent studies on EMDR therapy. This research not only deepens our understanding, but also reinforces the 6 key mechanisms of action I discussed in my 2016 conference presentation and in my textbook. We'll see how new evidence continues to shape and confirm what we know about how EMDR therapy works. Now, when we discuss mechanisms of action in psychotherapy, it's important to reference Alan Kasdan's seminal 2007 article, Mediators and Mechanisms of Change in Psychotherapy Research. Kasdan outlined 7 rigorous criteria for establishing a mechanism: strong association, specificity, consistency, experimental manipulation, timeline, gradient, and plausibility or coherence. These criteria set a high bar for the field. To date, none of the hypothesized mechanisms of EMDR therapy fully satisfy all 7 of Kasdan's standards, though some have been examined more thoroughly than others. Importantly, this challenge is not unique to EMDR therapy. No psychotherapy modality has explanations of their mechanism that meet all 7 criteria. EMDR therapy, however, often faces heightened scrutiny, likely due to Francine Shapiro's emphasis on neurophysiological hypotheses and the distinctive role of bilateral stimulation. This focus has made EMDR's mechanisms a subject of ongoing debate and research within the professional community. In today's research update, we will work our way through a combination of review articles, laboratory, and clinical studies that all help to answer the question of how does EMDR therapy work. We'll start with 2 narrative review articles that frame the range of clinical and neurobiological studies. We start with a review of mechanisms, physiological, and neural correlates of EMDR therapy. In their comprehensive review published in 2018, Landon Romero and colleagues set out to answer the question we are asking today: how does EMDR therapy actually work? To tackle this, they reviewed 87 studies, grouping them into 3 main categories: psychological, psychophysiological, and neurobiological models. Their goal was to understand not just the psychological effects of EMDR therapy, but also what happens in the body and the brain during therapy sessions. They reviewed working memory performance, autobiographical memory, vividness and emotionality ratings, autonomic factors such as heart rate, skin conductance, and heart rate variability, and multiple neuroimaging modalities including electroencephalography, single-photon emission-controlled tomography, near-infrared spectroscopy, structural and functional magnetic resonance imaging, and positive emission tomography. This allowed them to create a detailed picture of what happens before and during and after EMDR sessions. One of their primary findings was that the working memory theory has strong scientific support. When people engage in bilateral eye movements while recalling distressing memories, the vividness and emotional intensity of these memories tend to fade. This effect is especially pronounced when the person is emotionally engaged and their brain's stress systems are active. They found numerous studies that showed EMDR therapy sessions often begin with a heightened state of alertness, followed by a calming response in the body. Brain scans revealed that after successful EMDR therapy, areas of the brain involved in fear and emotion become less reactive, while regions responsible for control and regulation become more active. There are also hints that the brain's memory and sensory networks reorganize in positive ways. Interestingly, their review found that horizontal eye movements, the hallmark of EMDR, often have a stronger effect than other types of bilateral stimulation. Psychophysiological studies generally show patterns of initial orienting followed by parasympathetically mediated de-arousal across sets and sessions. Neuroimaging studies suggest normalization of hyperactive limbic regions, enhanced prefrontal control, changes in hippocampal and thalamic structures, and shifts from frontal limbic activation towards posterior associative regions after successful EMDR therapy. However, their review highlighted some important limitations. Many of these studies used small or non-clinical samples, and not all followed the full EMDR therapy protocols. This makes it difficult to draw firm conclusions about how EMDR therapy works, specifically for people with PTSD. They concluded that research on EMDR's mechanisms is still in its early days, and they made it clear it is likely that several distinct mechanisms work together to produce its effects. They call for larger, better controlled studies that combine psychological, physiological, and brain-based measures to build a more complete understanding of how EMDR therapy helps people heal. Next, we turn to a review of neurobiological theories. Clancy and co-authors published a narrative review in 2018 that synthesized clinical and neurobiological research on EMDR therapy for PTSD. They explored eye movement characteristics, large-scale brain networks, and cerebellar involvement. They integrated findings about 4 primary mechanisms of action, including taxing working memory, interhemispheric communication, memory reconsolidation through a slow-wave sleep analog, and orienting response theories through an examination of randomized controlled trials, eye-tracking studies, functional and structural neuroimaging, EEG, and transcranial magnetic stimulation studies. They found extensive evidence that EMDR therapy reduces PTSD symptoms, depression, anxiety, and subjective distress, typically in fewer sessions than exposure-based therapies and with more sustained effects than psychotropic medication. They also found that EMDR therapy enhances episodic memory retrieval, cognitive flexibility, attentional orienting, somatic awareness, and mindfulness. They reviewed studies indicating that dual attention tasks involving bilateral visual stimulation and eye movements taxed the visual spatial sketchpad and central executive components of working memory, decreasing vividness and emotionality of autobiographical memories with stronger effects for visual than either auditory or tactile bilateral stimulation. They found support for several neurobiological mechanisms, including increased interhemispheric communication during bilateral eye movements, modulation of amygdala and hippocampal memory traces via mechanisms analogous to slow-wave sleep. They described evidence for AMPA receptor depotentiation from postsynaptic membranes in the amygdala, thereby depotentiating previously strengthened fear synapses. They found evidence for de-arousal effects linked to reduced dorsolateral and lateral prefrontal cortex activation during alternating bilateral stimulation. They described converging evidence that a combination of predictive saccades and smooth pursuit eye movements generated at approximately 1.5 Hz during EMDR therapy preferentially engaged the default mode network and cerebellum while deactivating the dorsal attention and oculomotor control networks. They related these effects to known abnormalities of default mode, salience, and central executive networks, as well as limbic and orbitofrontal circuitry in PTSD. Their reviews cited the lack of real-time eye tracking during actual EMDR therapy, small samples, and single-case designs in many neuroimaging and electrophysiological studies, and the speculative nature of proposed synaptic and sleep-related mechanisms. Their conclusion was that EMDR therapy likely works by recruiting the cerebellum and default mode network through predictive and smooth pursuit eye movements, thereby facilitating internally guided cognition, associative learning, and memory reconsolidation while dampening prefrontal arousal and frontoparietal attentional network activity. They argued that optimizing bilateral stimulation to maximize predictive eye movements and using eye movement metrics as real-time biomarkers could individualize EMDR therapy delivery and potentially extend this network-based model to other psychiatric disorders characterized by default mode network dysregulation. Despite widespread evidence in support of the working memory hypothesis, there are studies that question the primacy of the working memory hypothesis. So next we consider two studies that review weakness in the evidence for the working memory hypothesis. Waji and co-authors in 2022 conducted a review of 11 studies investigating the working memory hypothesis. Half of these studies were experimental studies with healthy subjects. The other half were clinical studies. Their analysis found a reduction of vividness and emotionality in the recall of traumatic stimuli under a dual attention task condition compared to a control condition such as recall alone. However, of the two studies that used a follow-up test, this effect did not seem to last long as it completely disappeared over time. Next, we turn to a neurological study that found additional weakness in the evidence for the working memory hypothesis. In 2016, Tomas and co-authors used a randomized controlled crossover fMRI design with 8 adults with primary PTSD. Their research design was to compare recall with eye movements to a recall-only condition during script-driven imagery of personal traumatic memories. Their participants' PTSD diagnosis, comorbidity, and trauma history were assessed with a structured clinical interview for the DSM-IV. Symptom measures included the Post-Traumatic Symptoms Scale Self-Report, the State Trait Anxiety Inventory, State Subscale, the Beck Depression Inventory, and the clinician-administered dissociative state scale, as well as subjective ratings of distress, vividness, and emotionality during scanning. I need to point out that this was not actually a study of standard EMDR therapy, as the experimental intervention was only a fragment of the EMDR therapy procedure. During recall with eye movements condition, participants were asked to recall the traumatic image during 8 blocks of 24 seconds each, with a 10-second break in between, and to visually track a 1-centimeter dot moving from one side of the screen across to the other at a rate of 1 movement per second, while instructed to continue recalling the traumatic image. Again, I need to note that EMDR treatment guidelines instruct clinicians to gradually increase the speed of eye movements until they reach the fastest rate that avoids discomfort and is tolerated by the client. Other research suggests that speeds of 1.25 to 1.5 cycles per second appear to be optimal. Su and co-authors in their 2025 neural network analysis suggested the optimal speed for bilateral eye movements is 1.8 cycles per second. That recommendation is 80% faster than the speed of 1 cycle per second used by Tomas and co-authors in this fMRI study. Tomas and co-authors found that script-driven imagery across both conditions activated visual association cortex, dorsolateral prefrontal cortex, dorsal medial prefrontal cortex, and anterior insula. Subjective vividness and emotionality ratings did not significantly change over time or differ by condition, although general distress was higher after recall with eye movements than after recall only. This may have been due to the incomplete EMDR protocol used, as well as the relatively slow speed of eye movements. The primary imaging finding was that the right amygdala and rostral anterior cingulate cortex activity were significantly lower after recall with eye movements than after recall only. Functional connectivity between the right amygdala and the rostral anterior cingulate cortex was decreased after recall with eye movements relative to recall only. Predicted increases in dorsolateral prefrontal cortex activity and decreases in visual cortex activity were not observed. Tomas and co-authors noted several major limitations, including the very small sample size, loss of data due to panic, which is not uncommon in fMRI studies, movement artifacts, and technical problems, as well as a general inability to robustly relate neural changes to subjective measures. Overall, this study suggested that the eye movement component of EMDR therapy during traumatic recall might reduce activity and connectivity in key emotional processing regions in PTSD. Their finding did not provide support for a working memory explanation of these effects. In summary, they found evidence of emotional processing effects for EMDR, like bilateral eye movements, but their study found no evidence of degradation of memory intensity. We turn next to another fMRI study that found complex reorganization of neural networks during EMDR therapy. In 2019, Rousseau and colleagues in France conducted a rigorous randomized controlled fMRI study examining the effects of EMDR therapy compared to a waitlist supportive therapy group in 36 adults diagnosed with PTSD. In contrast to other neurobiological studies that use an individualized trauma script provocation, their methodology involved a cued fear conditioning and extinction paradigm using electric shocks during fMRI scans, both at baseline and after treatment. Each subject pre-selected the shock level they perceived as highly annoying but not painful. All participants underwent 2 fMRI scans, while the EMDR group received a third clinical assessment to determine remission. Repeated clinical evaluations were performed, employing standardized measures for PTSD, depression, and anxiety. On the standardized clinical measures, they found that only the EMDR group showed large decreases from baseline to follow-up on PTSD symptoms, depression, and trauma impact scales, whereas the waitlist group showed no significant clinical change. Both groups, those who received EMDR therapy and those who are on the waitlist, responded similarly when they were first taught to expect an unpleasant electric shock. However, when it came to unlearning that fear, the extinction phase, the EMDR group showed a much greater reduction in their expectation of something painful happening by the end of the study. In other words, after EMDR therapy, people were much less likely to expect fear or danger compared to how they felt before treatment and compared to the wait list group. Neurologically, the researchers found that EMDR therapy led to changes in activity across several key areas of the brain, including the amygdala, which processes fear, the hippocampus involved in memory, and regions responsible for attention and sensory processing. These changes were significantly different between the EMDR group and the waitlist group. When they looked at how these brain regions communicated with each other, they saw that after EMDR therapy, the connection between the left amygdala and the left temporal pole became stronger. The connection between the left hippocampus and the superior parietal lobe became weaker. The connection between the right insula and the ventral entorhinal cortex also became weaker. This means that EMDR therapy appeared to reorganize how certain parts of the brain involved in fear, memory, and sensory processing interact, which may help explain how EMDR reduces symptoms of PTSD. Limitations in this study included a small final sample due to substantial attrition, use of only 2 EMDR therapists, variations in medication use, various comorbidities, different types of trauma, and the possibility of expectancy effects between treatment conditions. Overall, they concluded that EMDR therapy for PTSD was associated with remission of symptoms and a healthful restoration of fear extinction learning. These changes reflected coordinated functional and connectivity changes in classical fear circuitry and other neocortical regions, suggesting that symptom improvement in EMDR treatment of PTSD yields complex reorganization of neural networks involved with fear, emotion, and memory, rather than due to a single locus of change. Next, we look at a PET scan study that showed an increase in precuneus metabolism after EMDR therapy in military veterans. First, let's take a moment to talk about the precuneus. This is a region deep in the brain, located on the inner surface of the parietal lobe. The precuneus is involved in several important functions, including memory, self-reflection, and processing visual and spatial information. It helps us integrate sensory input and is part of the brain's default mode network, which is active when we're resting or letting our minds wander. Now, let's dive into the study. In 2019, Rousseau and co-authors in France conducted a single-group pre-post study of 15 combat-exposed military veterans diagnosed with PTSD who completed up to 8 sessions of EMDR therapy. They were assessed with fluorodeoxyglucose PET scans during virtual reality exposure to a standardized war scene before treatment and within 1 month of remission. Clinical assessment used the Post-Traumatic Stress Checklist Scale and the clinician-administered PTSD scale before and after EMDR therapy. Subjective units of disturbance ratings were used to quantify their level of fear during virtual reality exposure. They reported that PTSD symptoms and subjective units of disturbance scores significantly decreased after EMDR therapy, and all patients no longer met criteria for PTSD. Rousseau and colleagues found that brain metabolism increased specifically in the bilateral precuneus, more pronounced on the right, during post-treatment virtual reality exposure, with no areas showing decreased metabolism. They found that the greater the increase in precuneus metabolism from before EMDR therapy to after EMDR therapy, the more there were decreases in the clinician-administered PTSD scale scores. Also, higher baseline precuneus metabolism predicted greater reduction in post-traumatic stress checklist scale scores. Rousseau and colleagues interpreted the increase in precuneus metabolism as supporting improved autobiographical memory, multisensory integration, and a more observer-like stance toward the trauma memory. Rousseau and co-authors acknowledged the small sample size, the absence of a waitlist or active control group, and the lack of imaging during EMDR therapy sessions themselves as main limitations. Overall, they found that EMDR therapy led to symptom improvement in combat-related PTSD that was associated with increased precuneus metabolism during virtual stress exposure. They also suggested that increasing precuneus functioning might represent a potential target for other neuromodulation approaches, such as repetitive transcranial magnetic stimulation or neurofeedback. As mentioned earlier in this episode, Clancy and co-authors in their 2018 review article proposed that EMDR therapy likely works by recruiting the cerebellum and the default mode network. Their proposal found additional experimental validation in a 2020 experimental PET study in France by Virgil Rousseau and colleagues. They conducted a prospective imaging study that used fluorodeoxyglucose positron emission tomography, sensitized by virtual reality exposure to war scenes before and after a full course of EMDR therapy. They recruited 15 male military participants with chronic PTSD related to Afghanistan or Mali combat deployments. All of their participants were free of prior exposure or cognitive behavioral therapy. They all became symptom-free after EMDR therapy, as determined by structural diagnostic interviews and large reductions on the clinician-administered PTSD scale and the post-traumatic stress checklist scale. The primary imaging measure was metabolic connectivity, of a bilateral precuneus region of interest defined from the previous work by Rousseau and colleagues in 2019 as the only area with increased metabolism after EMDR therapy. In the current study, this was assessed using interregional correlational analysis at the whole brain level on spatially normalized PET images acquired during virtual reality exposure. Mean metabolic values from significant clusters were correlated with clinical PTSD scale scores. The main finding was that connectivity between the precuneus and two large bilateral clusters in the posterior cerebellum showed a significant decrease after EMDR therapy compared with pretreatment scans. A secondary finding was that higher pretreatment cerebellar metabolism within these clusters correlated with lower PTSD symptom scores after EMDR, suggesting that baseline cerebellar function predicted better clinical response. This finding on higher pretreatment cerebellar metabolism is perhaps the first clear predictive factor for determining who will respond most strongly to EMDR therapy. Verger and co-authors acknowledged several limitations, including the small, all-male military sample, absence of a waitlist or alternative treatment control group, restriction of metabolic connectivity, analyses to a precuneus region defined from the prior research, and due to the lack of a control condition, the inability to disentangle mechanisms specific to EMDR therapy for more general remission effects. Their main finding was that remission of PTSD following EMDR therapy appeared to involve decreased metabolic connectivity between the precuneus and posterior cerebellum. They also found that higher baseline cerebellar metabolism was associated with greater symptom improvement, supporting an important role of cerebellar default mode network interactions in the therapeutic effect of EMDR therapy for PTSD. Next, we will explore mechanisms of action in a randomized controlled study comparing EMDR therapy and imagery rescripting. As I mentioned in the introduction to these studies, one of the 7 factors proposed by Kasdan for demonstrating mechanism of action is time course. In the analysis of this randomized study, we will see a classic example of how measuring changes over time can help assess the validity of theories of mechanism. In 2024, Ramekers and co-authors studied the mechanisms of EMDR therapy and imagery rescripting. They began with 3 hypotheses. First, they hypothesized that EMDR therapy works via changes in memory vividness, and second, that imagery rescripting works via changes in encapsulated beliefs, and finally, that both treatments work via changes in memory distress. Encapsulated beliefs are deeply held negative convictions linked to traumatic memories. Some common examples are, I am powerless, I am unworthy, and I am unsafe. In EMDR therapy, these encapsulated beliefs are referred to as negative cognitions. In their 2024 paper, Ramekers and co-authors conducted a secondary analysis of an earlier randomized controlled trial in which 155 adults with childhood-onset PTSD were assigned to 12 sessions of EMDR therapy or imagery rescripting, delivered twice weekly in routine clinical settings in Germany, the Netherlands, and Australia. PTSD severity was assessed with the clinician-administered PTSD scale for DSM-5 and the impact of event scale revised, and imagery-based mechanisms were assessed with the imagery interview, which measures trauma memory vividness, distress, and the believability of encapsulated beliefs linked to the worst childhood trauma. They found that both treatments significantly reduced both PTSD symptoms and all 3 imagery characteristics over time. EMDR therapy produced faster, early reductions in vividness, distress, and encapsulated beliefs, although overall PTSD outcomes did not differ between the 2 treatments. Ramekers and co-authors used Granger causality analyses to test whether changes in one variable systematically preceded and predicted changes in another variable over multiple assessment points. Their Granger causality analyses showed no evidence that changes in vividness predicted later PTSD symptom change in either treatment condition. During imagery rescripting, but not EMDR therapy, reductions in distress and believability of encapsulated beliefs consistently preceded subsequent decreases in PTSD severity, suggesting changes in negative beliefs were active working mechanisms for imagery rescripting, but not for EMDR therapy. In contrast, the relationship between changes in vividness and PTSD symptoms was not stronger in the EMDR therapy group, which fails to support the hypothesis that vividness is a specific mechanism of change in EMDR therapy. Thus, the working memory hypothesis that changes vividness are a primary mechanism of change in EMDR was not supported. Ramekers and co-authors noted several limitations, including relatively long intervals between assessments and a focus on only 3 potential mediators while omitting other candidates such as avoidance, emotional regulation, mastery, or alliance. Ramekers and co-authors concluded that imagery rescripting appears to work partly through changes in distress and encapsulated beliefs, whereas EMDR therapy, despite faster change in symptoms, revealed no clear causal mechanism in this research design. Next, we turn to an EEG study that explores the effects of bilateral eye movements on memory processing and whether the working memory theory provides a causal mechanism for EMDR therapy. In 2024, Wang and co-authors assessed brain activity with EEG analysis and compared an eye movement condition with an eye fixation condition. This was a non-clinical experimental study of short-term and long-term memory retrieval. Their EEG analysis revealed that bilateral eye movements enhanced neural representations of perceptual and memory information. Their research design and analysis explicitly explored both the working memory degradation model and the information processing hypothesis. The researchers found that when participants made bilateral eye movements, their working memory performance was actually a bit worse compared to when they kept their eyes fixed. This is because the dual task nature of EMDR, recalling memories while doing eye movements, can make it harder for the brain to juggle both tasks at once. However, the study also showed that bilateral eye movements broadly improved how the brain processes and represents information. EEG results revealed increased activity in the visual areas of the brain, the occipital region, and this increase was not just for things people saw, it also helped with retrieving long-term memories. Specifically, bilateral eye movements increase the flow of information between the visual region to areas involved in attention and higher-level processing in the frontal parietal region. This suggests that eye movements help the brain process and organize both new and old information more effectively. This may be one of the ways EMDR therapy helps people reprocess traumatic memories. In their discussion, they speculated that the information processing induced by bilateral eye movements contributes to PTSD treatment in 3 ways. First, they described how bilateral eye movements activate the perceptual and prefrontal brain regions, leading to suppression of the amygdala response, likely through an inhibitory feed-forward described in earlier research by Bake and co-authors in 2019. As a result of this inhibitory feed-forward, maladaptive emotional responses to traumatic memories are suppressed during EMDR therapy. Second, they propose that the information processing function of bilateral eye movements facilitates the processing of incompletely processed information caused by excessive emotional arousal, as described by Bruin in 2014. They propose, as did Stickold in 2002 and 2008, that EMDR therapy may facilitate the transition of sensory memory into semantic memory representation. Third, they suggest that the increased activation in perceptual brain regions and the enhanced perceptual representations during bilateral eye movements may interrupt the retrieved memories by enhancing visual spatial interference in EMDR. Next, we will consider 3 studies of eye movements, memory retrieval, and the theory of mechanism of increased interhemispheric coherence in EMDR therapy. All three are experimental, non-clinical studies. Briefly, as early as 2007, in an EEG study, Proper and co-authors found that the eye movements used in EMDR led to changes in interhemispheric interaction when subjects kept their eyes open after sets of bilateral eye movements. They found that engaging in bilateral eye movements led to decreases in interhemispheric gamma EEG coherence, which they interpreted as supporting the interhemispheric hypothesis for some of EMDR therapy's effects. Earlier, in 2003, Chrisman and colleagues conducted 2 experiments to see if moving your eyes back and forth for 30 seconds could help remember things better. They tested this using both word learning tasks in the lab and recall of everyday events recorded in journals. Their results showed that horizontal eye movements improved people's ability to tell apart words they had studied from new ones and made them more careful in their responses. Vertical or smooth pursuit eye movements did not have this effect. When it came to recalling personal events, horizontal eye movements again helped participants remember more accurately, raising correct recall rates and lowering mistakes compared to a control condition. Although the study did not directly measure how the two sides of the brain interacted, the authors suggested that these brief horizontal eye movements likely boosted communication between the brain's hemispheres. They suggested that part of the therapeutic benefits of the bilateral eye movements used in EMDR therapy may have more to do with helping patients with PTSD overcome their dissociative amnesia and retrieve episodic memories for traumatic events than with merely decreasing emotions related to the traumatic event. More recently, Neuenhaus and co-authors in 2013 conducted 3 laboratory experiments with strongly right-handed students using word recall tasks to test whether alternating bilateral sensory stimulation in visual, tactile, or auditory modalities enhanced episodic memory retrieval compared to well-matched control conditions. They wanted to explore the hypothesis that the rapidly alternating activation of the two hemispheres that is associated with a series of left-right eye movements is critical in causing the enhanced retrieval. The memory tasks they used involved a mixture of neutral and negative Dutch words, followed by a distraction task, and then either horizontal eye movements, alternating tactile hand taps, alternating auditory tones, or simultaneous non-alternating visual, tactile, or auditory stimulation. They found that both horizontal eye movements and alternating tactile stimulation significantly improved recall relative to their control conditions without increasing false memories. Alternating auditory stimulation did not produce these effects. None of the non-alternating forms of stimulation produced these effects. They concluded that memory retrieval effects of alternating bilateral visual and tactile stimulation supported the interhemispheric activation theory. Next, we consider 2 commentaries on how EMDR therapy may reproduce the effects of slow-wave sleep. Pagani and co-authors in 2017 published 2 commentaries that proposed a neurobiological model outlining how EMDR therapy might reproduce the neurophysiological conditions of slow-wave sleep to explain its clinical effects in PTSD. The article summarized prior EEG and neuroimaging findings, basic sleep and synaptic plasticity research, and theoretic models such as the adaptive information processing model, the orienting and relaxation response, the working memory hypothesis, the thalamic binding hypothesis, and the rapid eye movement sleep hypothesis to build their conceptual framework. They summarized clinical and neurophysiological evidence that EMDR therapy produces changes in limbic and cortical regions, with EEG studies showing a shift of cortical activation from limbic to cognitive regions during successive sessions. They noted that during EMDR therapy, bilateral eye movements occurred at approximately 1 to 2 cycles per second and were associated with delta activity in the EEG signal, similar to that seen in slow-wave sleep as well as with beta activity. Their main proposal is that low-frequency bilateral stimulation in EMDR therapy mimics the slow oscillations of slow-wave sleep, favoring depotentiation of overpotentiated amygdala synapses, weakening traumatic emotional memory while preserving episodic content and facilitating transfer and integration of memories from hippocampal amygdalar circuits to associative neocortical networks. They further suggest that this slow-wave sleep-like mechanism could reconcile and extend orienting and relaxation response, working memory, and rapid eye movement sleep theories by providing a common synaptic plasticity and memory reconsolidation account. Pagani and co-authors acknowledged that their model was speculative and rested on indirect evidence and lacked direct experimental tests of molecular, electrophysiological, and imaging correlates of their proposed mechanism for EMDR therapy. Nevertheless, like Robert Sickold more than a decade earlier, in 2002 and 2008, they proposed that EMDR therapy might induce slow-wave sleep-like brain states that support depotentiation and reorganization of traumatic memories. They called for integrated neurobiological, cognitive, and clinical studies to validate and refine this potential mechanism of action. Next, we will dive into the thalamocortical binding hypothesis. First, a brief overview of the thalamus. The thalamus is a centrally placed hub that serves as the brain's main relay hub, filtering all motor and sensory signals except for smell, and directing these signals to the cortex, while also shaping attention, arousal, and consciousness through thalamocortical loops. The thalamus regulates information flow, modulates sensory processing, and supports states like wakefulness via interactions with reticular nucleus and cortex. The thalamus has two distinct modes, tonic mode and burst mode. Tonic mode supports relatively faithful continuous encoding of the full range of sensory inputs. Burst mode is like a digital alert with a narrower range of throughput, but with more impact, optimized in effect to say, pay attention to novel events such as traumatic threats. The thalamocortical binding hypothesis for EMDR therapy was first proposed by Ulrich Lanius and Uri Bergman in 2014. They proposed that alternating bilateral sensory stimulation plays an important role in adaptive information processing by directly affecting activity in the thalamus. They explained that alternating bilateral stimulation at the frequency used in EMDR therapy modulates oscillatory activity in brain and contributes to the synchronization of dynamic neuronal networks across multiple brain subsystems. Their hypothesis has been explored and supported by several recent studies. Perhaps the most compelling research to support the thalamocortical binding hypothesis came in a mouse model study published by Bake and co-authors in 2019 that was further described by Holmes that same year. Bake and co-authors in 2019 used a mouse model of auditory fear conditioning followed by extinction training combined with various forms of visual stimulation to identify the neural circuits that could explain the enduring fear reductions observed after EMDR therapy for PTSD. They measured freezing behavior along with single-unit recordings through wires into the mice superior colliculus, medial dorsal thalamus, and basolateral amygdala. They also used optogenetic activation and silencing of defined pathways and conducted whole cell recordings to assess inhibitory and excitatory synaptic transmission over multiple time points after fear conditioning and extinction. They found that pairing extinction with alternating bilateral visual stimulation markedly reduced freezing during extinction and prevented spontaneous recovery and renewal a week later, whereas continuous or flickering light stimulation did not. Alternating bilateral visual stimulation robustly increased tonic firing in superior colliculus neurons and enhanced excitatory drive in the superior colliculus medial dorsal thalamus pathway, which was necessary and sufficient to prevent fear return. In the basolateral amygdala, alternating bilateral sensory stimulation selectively suppressed fear-encoding neurons. and produced a sustained increase in inhibitory postsynaptic currents that paralleled long-lasting behavioral fear attenuation. Researchers found that when they interfered with the normal activity of medial-dorsal thalamus through optogenetic suppression, the positive effects of alternating bilateral visual stimulation, like the kind used in EMDR, disappeared. This means that steady, ongoing tonic activity in the medial dorsal thalamus is necessary for the benefit of EMDR therapy to occur. They discovered that the medial dorsal thalamus communicates directly with the brain area involved in fear, the basolateral amygdala. This connection helps to turn down or inhibit fear responses. After using alternating bilateral stimulation, this inhibitory effect was stronger, making it harder for fear signals to get through. This effect lasted for at least a week after the therapy. Bake and colleagues pointed out several limitations in their study. First, they used mice instead of human participants, so the results may not fully translate to people. Second, their research focused only on bilateral visual stimulation without directly measuring mouse eye movements, and thus did not directly test the effects of standard bilateral eye movements as used in actual EMDR therapy. Third, because the study was done in animals, it couldn't capture the full range of thoughts and feelings that are part of the human experience during EMDR. Despite these limitations, the researchers found evidence that a specific brain circuit connecting the superior colliculus, medial dorsal thalamus, and amygdala may help explain how alternating bilateral stimulation, like that used in EMDR, can lead to lasting reductions in traumatic fear. Later in 2019, Holmes published a highly readable commentary in Nature summarizing the Bake study. He wrote that combining extinction training with alternating bilateral stimulation produced a robust and persistent reduction in freezing, and that activity in the superior colliculus and medial dorsal thalamus predicted the extent of fear reduction. He emphasized that the pattern of alternating left-right, but not random, visual stimulation was critical, leading to the proposal that alternating bilateral visual stimulation shifted the balance among competing neural circuits towards ones that favored extinction rather than persistent fear. We will look next at two more studies that consider the central role of the thalamus in PTSD and in EMDR therapy. The role of the thalamus in EMDR treatment of PTSD was discussed by Yoshi in a 2021 review article. In this paper, Yoshi commented on the 2019 Bake study regarding how EMDR therapy-like stimulation in mice produced sustained superior colliculus medial dorsal thalamus activation. He also cited the work by Bossini and co-authors, which I will discuss in a moment, which showed increased gray matter volume in the left parahippocampal gyrus and significant decrease in gray matter volume in the left thalamus region. Yoshi concluded that the research on the efficacy of EMDR therapy for treating PTSD supports the understanding that the thalamus may be a key site of PTSD pathogenesis. Our final study about the role of the thalamus in EMDR therapy is an MRI study carried out by Bossini and co-authors in 2017. This was a longitudinal case study that compared 19 adults with PTSD to 19 matched healthy controls, all scanned with brain magnetic resonance imaging at baseline and 3 months later. PTSD diagnoses were established with a structured clinical interview for DSM-4, and symptom severity was assessed with the clinical administered PTSD scale and the Davidson Trauma Scale, while depression and anxiety were evaluated with the Hamilton Depression Rating Scale and the Hamilton Anxiety Rating Scale. Patients received 12 weekly 90-minute sessions of EMDR therapy delivered over 3 months by trained psychotherapists, and both groups underwent repeated brain MRI. The patients were also reassessed clinically at the second time point. Bossini and co-authors found that before treatment at baseline, that patients showed significantly smaller gray matter volume in their left parahippocampal gyrus, supplementary motor area, lingual gyrus, and bilateral superior frontal gyri, and larger gray matter volume in specific areas of the parietal cortex and temporal cortex. Gray matter concentrations did not differ between groups. Over 3 months, healthy controls showed no MRI changes, whereas patients exhibited a significant increase in gray matter volume in the left parahippocampal gyrus and a significant decrease in gray matter volume in the left thalamus, thereby normalizing their baseline neurological issues. Patients started with moderate to severe PTSD symptoms, and after 12 EMDR therapy sessions showed a marked reduction in PTSD scores, with 16 of 19 no longer meeting diagnostic criteria for PTSD. Their secondary findings indicated that structural normalization in hippocampal and parahippocampal regions seemed to parallel improvements in memory processing of thalamic material, and that the thalamic volume decreases might reflect reduced hyperactivation associated with re-experiencing and altered thalamocortical connectivity. They interpreted the hippocampal volume increase as potentially reflecting restoration of synaptic and dendritic connectivity and improved integration between subcortical limbic regions and cortical areas. They linked the thalamic changes to decreases in emotional overengagement with traumatic memories. They proposed that EMDR therapy exerts its clinical effects in part through modifying brain structures central to memory encoding and emotional regulation in PTSD. Bossini and co-authors acknowledged their small sample size, heterogeneity in trauma type and load, and the lack of follow-up to determine durability of both symptom and volumetric changes over time. Their main takeaway message was that successful EMDR therapy in PTSD patients appeared to be associated with measurable brain morphovolumetric normalization, especially increased left parahippocampal and hippocampal volume and decreased thalamic volume, which paralleled substantial clinical remission and suggested that EMDR therapy can help reverse structural correlates of PTSD. For our last study, let's consider research on the beneficial effects of EMDR therapy on mindfulness, mentalization, and reflective function. Many of the neurobiological studies cited in this episode show that the bilateral eye movements employed in EMDR therapy directly contribute to improvements in attentional flexibility and executive functioning, which are central to mindful noticing. Keller and co-authors in their 2014 paper described these prefrontal benefits in their amygdala anterior cingulate prefrontal cortical coupling model. In addition to the extensive neurological research, there are also fascinating clinical studies that indirectly reflect the neurobiological effects of EMDR on capacities for mentalization and reflective function. For example, this has been done using the adult attachment interview to assess attachment classification and capacity for reflective function. Research has linked AAI classifications to distinct fMRI findings, as was described in a 2012 paper by Vertica and Viume. A wonderful illustration of this kind of EMDR clinical research on reflective function is a 2019 paper by Civility and co-authors. They conducted an exploratory one-group pre-test, post-test pilot study with 20 Italian outpatient women who presented with parenting and relational difficulties. They were also selected due to primary or secondary unresolved or disorganized attachment, as assessed with the adult attachment interview. They each received individual EMDR therapy over about 12 months from 2 certified clinical psychologists, with 28 to 44 individual sessions per patient, and fidelity checks on randomly selected sessions. Attachment state of mind and reflective function were assessed before EMDR therapy and again after 12 months using the adult attachment interview, its narrative coherence scale, and its reflective functioning scale applied to adult attachment interview transcripts. The reflective functioning scale provides an overall score of reflective function from 1 to 9 based on the complexity of mental state understanding evident in interview narratives. The main finding indicated that at the initial pre-treatment assessment, none of the women had secure attachment, and half were classified as primarily unresolved. After EMDR therapy, all primary and secondary unresolved classifications were resolved. The authors reported that 12 of the 20 participants had moved to an earned secure status. The few remaining unresolved scores had significantly decreased, and narrative coherence as well as reflective function significantly increased from pre to post-treatment. Of course, this sample consisted only of 20 women in private practice, which limited generalizability and statistical power. Attachment was assessed solely with the adult attachment interview without other standardized symptom or relational measures. Their design lacked a control group, so other therapeutic or contextual factors beyond EMDR therapy might have contributed to the observed attachment and reflective function changes. Nevertheless, they concluded that EMDR therapy facilitated a move from unresolved to more secure states of mind with respect to attachment, accompanied by higher reflective function and more coherent narratives of early caregiving experiences. These patients became better able to access adaptive information and discuss traumatic memories without emotional disorganization. Civiliti and colleagues proposed that EMDR therapy supports resilience and improves the capacity to mentalize for self and others. This is a crucially important benefit for these primary caregiver capacities to offer reflective capacity to their children. The authors emphasized the need for larger controlled and follow-up studies to confirm the robustness, specificity, and durability of these changes in attachment status and reflective functioning. That's it for today's episode of EMDR, the Science Behind the Therapy from Sonoma Psychotherapy Training Institute. We hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. All the articles mentioned or covered in this 8th episode of the podcast can be found at sonopti.com/blog in the March 2026 listing or by clicking the link in the show notes. For a deeper look at EMDR therapy's mechanisms, see Chapter 2 of my textbook, A Guide to the Standard EMDR Therapy Protocols for Clinician Supervisors and Consultants. You can also find my 2016 conference presentation as a video or a free PDF at andrewleeds.net. Just check the show notes or the March 2026 blog post for direct links. If you enjoyed this podcast, help support the podcast by following, rating, or sharing it with fellow therapists. For information on our unique EMDR therapy training program, visit sonopti.com. And for free articles on EMDR therapy, visit the resources section on andrewleeds.net. Thanks for listening. We'll see you next time.